Hello and welcome to your IV therapy presentation. We'll be covering topics on pages 35 and 36 in my new 8th edition ATI textbook. We'll also be covering additional IV information about fluids not found in your ATI textbook, so please be mindful of the items in this presentation. In this presentation, we'll cover the following course objectives by defining the terms of a primary IV and secondary IV piggyback, describing the parts of an IV tubing, discussing IV infusion by gravity as well as by an IV infusion pump, and identifying types of complications associated with IV access and infusions. Advantages and disadvantages of IV therapy. Advantages of getting an IV solution is that it has a rapid effect, it has a precise amount that you can deliver, it is less discomfort for the patient instead of being continuously stuck. They only have the discomfort of the initial IV insertion, and then following that, they should not have discomfort afterwards. You can also maintain a constant therapeutic level through continuous infusions, as well as there's less irritation to the subcutaneous and muscle tissue layers. The disadvantages of receiving IV fluids can include fluid overload. That's when there's too much fluid in the system and all the fluid is building up in the patient and they start to swell, have crackles on the lungs, the fluid disperses into all of the other tissue areas where it should not be, and you have a lot of complications, as we will see at the end of the presentation. Other disadvantages include that an IV infusion, you have immediate absorption, which leaves little time for the nurse or the physician to correct any problems or errors or adverse reactions of that medication. There's also potential of irritation to the vein that could be based off of the size of the vein, the size of the catheter, IV catheter in the vein, or the medication itself can be irritating to the vein. You also can have local and systemic infections if that site is not cleaned properly and kept aseptically clean throughout its duration. This is an easy way for an infection to enter the body through the IV catheter. So it's important that you maintain clean asepsis technique every time you access their IV. When we access IVs, typically you will access the peripheral veins. You'll see in these pictures there are multiple veins. Peripheral veins are, of course, the outer extremities. This is the most common place that we access an IV. IV being intravenous, meaning we go for the vein. Therefore, when we're finding our placement for an IV, what we're feeling should not have a pulse. The pulse means it is an artery, not a vein. When we access a vein, typically it will be in one of these peripheral sites. You'll see the most common one in practice will be the AC, which is antecubital, which is our shorthand term for the accessory cephalic veins. That's in the antecubital space in the bend of the elbow. That's where those large veins come together, as you can see in the picture. And those being larger veins, they are easier to access. Other access types include the jugular and subclavian veins. These will be accessed for like PICC lines or ports, and that will be for long-term IV infusions, such as with chemotherapy or long-term antibiotics for patients that are taking these at home or intermittently at home, or for medications that can be irritating to the peripheral vein. Then they need to be given to a more central vein, such as the jugular and subclavian veins. Okay, so now we come to the anatomy of fluids and the tubing. As you can see on the picture on the left, this is a solution of sodium chloride injection. It also has clearly labeled its expiration date. Yes, fluids do expire. It will also tell you the amount that is on there. This bag has 250 milliliters of this solution in this bag. At the bottom of the solution, you will see typically at least 2 ports. One port is for medication administration to be added to this medicine. Sometimes this is done prior to the bag coming to you in pharmacy. Sometimes you will have to add a medicine to the solution and you do it through this port. The other port, typically the longer of the 2 ports, is the port that you will use to access with your tubing. The picture on the right is your tubing. Your tubing has a spike at the top. The spike is used to attach to the IV bag fluid. Once inserted, you will fill the drip chamber about halfway. There is usually a hazy line there, halfway, so that no air enters the rest of the tubing. The tubing then follows around until a roller clamp is typically present on most tubing. This clamp, once rolled all the way down, will clamp off the tubing completely. You can adjust the drip based off of the roller clamp by slowly closing it or closing it completely, which therefore stops the solution from being infused. Then the solution continues further down. You will see a sliding clamp. This is just to clamp it immediately. Then there's a medication administration port. Typically, once this is connected to a patient, you can administer through the line through this port. However, you will need to clamp using that slide clamp or pinching above the line from that medication administration port while you administer the medication to ensure that the medication is going towards the patient and not up the tubing. And then at the very end of the tubing, you will see the lure lock adapter piece that connects to the patient's IV catheter. Some medications can be infused through a long period of time or through intermittent infusions. So intermittent infusions you will see mostly in the form of secondary infusions or piggybacks. You'll see those commonly abbreviated as IVPB for IV piggyback. Those will be these small bags of solution that they only need for a short period of time and the treatment is over. They only needed so much fluid or so much antibiotic for that short period of time and then it's done. Also, intermittent infusions you'll see for volume control in pediatrics. This picture on the top is a pump, but it is infusing from a syringe instead of a bag. So pediatrics, of course, we dose a lot by their weight, so they may only need 20 milliliters of a medication, and therefore using a syringe pump, you can infuse that 20 milliliters of a solution over a controlled rate. Next, we have an IV bolus or IV push. These can be abbreviated as IVB or IVP. This is when an amount of medication is infused over a short period of time, but at a safe rate. This does not necessarily mean that you need to push it rapidly. Certain medications may be ordered as a push, but you still need to be mindful of how fast you push it for any complications. Sometimes the medications may need to be diluted in order to decrease that irritation to the vein. When you are diluting or pulling up a medication to give to a patient, that syringe, as you can see in the picture, should be labeled with the name of the drug, the strength, and the nurse's initials who put it in that syringe. Sometimes, and a lot of times, we dilute medications with normal saline in the normal saline syringe. The syringe says normal saline, but I have added morphine to it. If I leave that medication on the bedside table, another person may think that it is only saline solution if it is not labeled, even though it technically is diluted morphine. It is very important to have your medication syringes labeled. And once you administer an IV push or bolus, it will be important for the nurse to observe for any immediate adverse effects, because this can be instantaneous. You could not only have an IV bolus or push of a small amount, but also you could have an IV bolus of fluids, such as a large volume of like a liter of fluids. This is because that patient needs it rapidly now. So it's not necessarily a small amount, but when it is a small amount, you need to be mindful and always check for adverse effects. A continuous infusion of IV fluids is also a thing to be mindful of. These fluids are connected to the patient and infused over a long period of time, typically at a controlled rate. It can be controlled through an IV pump, or as this bottom picture is a dial flow. So this is a spiked tubing that spikes into your IV fluid, and instead of connecting through the IV pump, you can turn the dial to a certain setting of what rate you would like to administer it by. So these numbers would be 40 milliliters in an hour, or at a rate of 50 milliliters per hour, depending on the order. And this dial flow will keep it at that constant rate until the infusion is complete, without the use of a pump. Now we have infusion by gravity. You can hook up a saline bag or whatever type of solution to a patient without a pump, and therefore it is only infusing by gravity. You have to be mindful of this because not all of the medication or solution may be infused once the volume gets to a certain lower level. You may need to increase the height of the bag in order for it to infuse by gravity. That being said, when we use secondary bags of IV medication, as in what is in this picture, we want this smaller bag to infuse prior to all of this 1 liter bag of fluids. So I raise it higher. The higher the medication, the faster or the priority of the medication being infused will go. So that smaller bag of fluid will infuse first, then once it is empty, the lower bag will then start infusing. It will take over. So it is being hung by gravity. Even though this could be hooked up to a pump, the pump will not know that it is delivering 2 different medications at different periods of time, but the higher medication will always be infused first. The lower medication will wait its turn. So we have primary and secondary infusion, like we stated on the last slide. So primary is the main solution that is being administered. Typically this is a continuous infusion, but it can be stopped to allow for intermittent infusion, the secondary. The secondary typically is an intermittent infusion applied by gravity, and that is when you apply the hook to the primary solution. The primary infusion will then take over once the secondary infusion is complete. So my primary bag is hung. Now I need a secondary bag. The hook goes on my primary solution to drop it lower so that my secondary is higher and infuses first. Now we come to the types of IV solutions. Later in the program, we will associate what kind of fluid is which type of solution. But for the basic concept for now, we need to differentiate between a hypotonic solution, an isotonic solution, and a hypertonic solution. So in a hypotonic solution, there's less of the concentration, which makes the cell swell up as the water moves into the cell. Remember, this is all trying to create an equilibrium. So if there is less on the outside, the body wants it to be equal, so it is going to put it on the inside of the cell to equal out. In an isotonic solution, it's the same concentration as what is in the cell. So what movement out is the same movement in, so it is equal. There is already equilibrium, no change. In a hypertonic solution, there is a higher concentration outside the cell, and therefore the water in the cell will move out of the cell to create an equilibrium and therefore shrinks the cell. This can cause cell lysis and can break the cell apart if it shrinks too deeply. Think of this as a slug. If a slug is introduced to salt, which would be a high concentrated solution, salt water, then he will shrivel up. If he is exposed to a water solution, not much will change, the isotonic solution, right? Okay, next we come to complications of an IV therapy. First, we will talk about infiltration. Infiltration is typically seen as pallor, so paleness of the skin. There may be swelling at the site. It be cool to touch, so there's a decreased skin temperature around that site, and the dressing may be damp. The infusion may be slowed, therefore the pump will be beeping at you. You should stop the infusion and remove the IV. You may need another IV elsewhere, but be mindful if you do it near this area. If it's connecting to the same vein, you may have the same problem again in a few minutes. You need to treat this with a cold or warm compress, and elevate the extremity and encourage range of motion, especially if it's in one of the joint areas, which is mainly where we get our IVs, as I said, in that antecubital space. So be mindful that that swelling could interfere with the joint range of motion, so you should assess that range of motion frequently. Next, we will talk about catheter embolus. So catheter embolus, this is like when your IV is being discontinued, but a portion of the catheter did not come out of the patient. The tip of the catheter is broken off and dislodged into the patient's vein. This can be painful sometimes, not all the time. The pain is only associated if the piece moves. If you notice this, you should apply a tourniquet above the extremity, above the site on that extremity, to prevent it from further migrating, like into the rest of your circulatory system, and then your heart, and then you die. So applying that tourniquet is the first step. They may need surgery in order to remove it. They may be able to aspirate it. Different things may have to happen. Do not reinsert the stylet of the needle into the catheter to try to obtain it. Just leave it alone and let the surgeon deal with it. There may be other kinds of embolus, so clots that may form in the IV itself, the catheter. This can happen if you're not flushing your IV to ensure patency as you're supposed to on a frequent basis. So blood backs up into the catheter tip and stays there, and blood that stays clots. Therefore, a clot forms in your catheter tip, and when you go to flush it later than you were supposed to, now you flush a clot into their system. Small clots be fine, they can dissolve them, but if it is difficult to flush, never power flush it. because that clot may be too large. Next, we will talk about a hematoma. Hematomas can occur for a variety of reasons. The most common one is when you remove the IV catheter. The catheter, of course, you need to apply pressure to the site that the catheter was in so that it does not bleed. But commonly, well, not commonly, but commonly misthought of to continue to hold pressure after it stops using. Some people believe, oh, it stopped bleeding outside of the skin, so it was fine, but in an hour, they come back with a hematoma. You need to continue to apply pressure longer than just the oozing to have stopped. This is because the bleeding still occurs underneath the skin into those layers and continues to form larger and larger until something compresses or it clots off. This, of course, needs to be applied pressure to the site in order to decompress it and prevent it from continuing to increase in size. Another reason a hematoma could occur is if a patient is on blood thinners and you access their IV, their vein, and it starts to seep around the catheter and begins a hematoma next to your IV site. This can also happen when you insert an IV on anyone in general and the tourniquet is left on too long after you've already accessed the site. So we'll get to the specifics on the steps, but it is important that you remove the tourniquet at a certain time to prevent this from happening. You can apply a warm compress and apply pressure and elevate, trying to stop the bleeding. Extravasation, as you can see, is when the fluid is being infused either too fast or not controlled enough, like through gravity, that the vascular system cannot process it fast enough, so it starts to seep into the layers near that IV site. So this can be painful, burning, redness, swelling. You can get little pockets of swelling like this as well. You need to stop the infusion, notify the doctor. Different facilities have different protocols about what to do about this. There are some antidotes to certain medications because these are typically medications that have an irritating or vesicant tissue damaging effect, and so administering an antidote can decrease these side effects and extravasation to that area. So closely monitoring the site frequently so that you see this if it happens early, and use an IV pump whenever possible. Real life, especially in the ER, you hang it through gravity or dial flow, or you do it by eyeball with your clamp, but you always need to be checking that site frequently. Phlebitis or thrombophlebitis, this is essentially an infection that has entered because of an IV access. So either someone didn't wash their hands, didn't clean the hub before accessing the port to deliver medication. We will always scrub the hub with an alcohol wipe before giving anything to the patient. This is their vascular system. Any bit of microbe can irritate those veins. So you'll see this as swelling called edema. It can be throbbing, burning, or painful. There's an increase in temperature in the site. Again, this is an infection. An erythema, which is the redness. The red line may come up the arm, as you can see in the picture. It's following the line of the vein. And it may be palpable at the vein site. And of course, because of the swelling, because of the infection and process that's going on. Your IV infusion is going to be slowed down. So you need to discontinue the infusion or remove the catheter because it is now dirty. It is a dirty needle catheter. Elevate the extremity, apply a cold compress at first to minimize the blood flow to the area, and then a warm compress later to improve the circulation after you have begun treatment of the infection. You may need to culture the site in order to get a good treatment of whatever infection it is. So when you remove that IV, you may need to keep that catheter. It may be requested for a culture. You can prevent this by rotating your sites every 72 hours or sooner or per protocol. That's why in hospitals, typically we only want them to stay for about 3 days. You need to assess your sites frequently. Avoid in the lower extremities. They don't have as good as return of flow because they are subject to gravity more than your arms. Your arms you move around and do more things with. You also need to do hand hygiene, of course, and surgical aseptic technique anytime that you access their vein or their IV tubing. Next, we'll talk about cellulitis. Cellulitis, you'll see, is painful, it is warm, and there's edema, there's red streaking, they can have fever, chills, and malaise. This is not just infection to the vein, but now the infection has spread to the layers of the skin. You need to stop the infusion and remove the catheter, elevate the extremity, kind of all the same things, applying a warm compress multiple times a day. My book says 3 to 4 times in a day. Obtain a specimen from that catheter once you remove it, just like before, and you need to administer an antibiotic to treat the infection, an analgesic for their pain, and an antipyretic for their fever. Again, the same ways to prevent this would be to rotate the IV site about every 3 days, avoiding the lower extremities, and using your hand hygiene and aseptic technique. The last complication that we will talk about is fluid overload. This is when there is an overwhelming amount of fluid in the body that the body cannot process, and so it puts it in different areas. So you'll see the fluid build up in the abdomen, in the lungs, in the feet, in the legs. Everything starts to swell up, and that is wet fluid. So wet fluid on your lungs, they're going to have shortness of breath, they're going to have cough, they're going to have crackles in their lungs. You have extra fluid volume throughout your whole body. So your veins may be distended, especially your neck veins, and when we assess them. Tachycardia, because you're trying to push around that excess amount of fluid. At a faster rate, your heart rate has to increase in order to push all of that around. So if you see any of these symptoms even begin to start happening, you need to slow or stop the infusion because they cannot process it. Raise their head a bed so that they can breathe easier. And if any of the fluid, it does start to seep into the different areas. Hopefully it won't be the lungs as much because the lungs you have now made higher than the rest of the body. Assessing their vital signs and oxygen saturation because the fluid may be on their lungs and affecting their heart rate and blood pressure. You may need to consider a diuretic to get that fluid off. We were giving them fluid because they needed it for whatever reason, but it was too much. So actually we need to get that fluid off of them now. And diuretics, which we'll get into later, will pull all of that fluid back into their circulatory system instead of these areas back into their system so that their kidneys can process and pee it out. To prevent this, you need to use an infusion pump and monitor their eyes and nose. If fluid is going in, fluid should be coming out. If it's not coming out, it's going somewhere else, and you need to check where it's going. This concludes the presentation on IV therapy. You can find some of these topics on the following pages listed for your reference on this presentation. From the 8th edition, the new textbook, pages 35 and 36. If you have any questions from this presentation, please bring them to lab next week to discuss. Thank you. Have a good week.